I believe there's been a continuing evolution to look at the lipid-lowering effects of the PCSK9 inhibitors, and particularly two trials that were presented, or two presentations at the opening late-breaking trial session. The Fourier trial and the Spire trials are of particular interest. The Fourier trial showed important outcomes in patients that already were on statin therapy with modest control, not tight control, but modest control on moderate to high dose statins, and showed a substantial risk reduction. And it appeared as though that risk reduction was getting greater year by year, and so it may have even greater effects long term. And along with the Spire trials, which also looked at lipid lowering by a different PCSK9 inhibitor, they both showed dramatic improvement in LDL levels, but also showed improvement in outcomes. Now, this supports increasingly this LDL hypothesis that so many have held for so many years, that lower is better. And it also looked at dramatic lowering, where LDL cholesterols were down in the 20s, the 30s, and sometimes the 40s, but really dramatically low LDL levels with very, very low event rates. It also is remarkable, particularly in Fourier, that there was a dramatic reduction in event rates, even though the baseline event rate was so low because of expert treatment of the patients independent of the PCSK9 inhibitors. So this is going to allow us to look further at mechanisms of disease and ways that we might treat our patients to significantly reduce cardiovascular burden. Certainly, our guidelines task forces are meeting now, and they're working on the lipid guidelines. And as you recall, in 2013, the ACC AHA guidelines looked more at dosing of statins rather than absolute levels, based on the science that was available at that time in the randomized controlled trials that had shown good outcomes based on dosing. Since then, we've had some substantial additional evidence, including the IMPROVE trial and now the PCSK9 trials, that really are pushing us more toward looking at dramatic lowering of LDL. We also learned from the Spire trials that at least in those, there was not a homogeneous response curve with regard to all of the PCSK9 drugs, and that following LDL may be helpful. I believe that we're likely in the future at some point to be driving LDL levels much lower than we have in the past, and we certainly need to look very carefully at how we approach this with regard to targets. I also will say, however, in defense of the old guidelines, that the intent of making certain that patients who presented with, for example, acute myocardial infarction were aggressively treated regardless of whether or not they had a high or low LDL level is really crucial. So that patient that presents with an acute coronary syndrome who has a relatively low LDL level still needs to be treated.